Good afternoon, everyone. What I'm going to talk about today is adolescent with sexually transmitted infection or STI. And during the next 20 minutes, we will focus on the clinical management of common STI in adolescents. And we have three short interesting cases today and also the update on STI prevention. And let's begin with the first case. A 19-year-old man came to see us at the clinic with a tongue mask for 6 months ago. He was MSM with both insertive and receptive anal intercourse. And from the picture, do you think what is the most likely diagnosis for this patient who shows syphilis infection? Please raise your hand. Okay. Oral candidiasis or herpes simplex virus infection. Okay, let's see the provocations. We suspected for the syphilis infection called the lesion of condyloma lata. So we performed the tripronemal test and the result was reactive with the RPR 1/128. And we also performed the anti-HIV test and the result was negative. So we prescribed the benzathine penicillin G single dose and also started oral daily PrEP due to his at risk of HIV infection. And after that, we follow up him 1 week and the result resolved already. So the diagnosis was syphilis infection, and the syphilis is a systemic disease caused by treponema pallidum, and this disease has been divided into stages on the basis of clinical findings, which will guide the treatment and follow-up. And the common findings that we have found are painless genital ulcer for primary syphilis and MP rat, bumps and sores for secondary syphilis. And in this case, we demonstrate the other findings for secondary syphilis as you see in the picture. And the syphilis can infect the CNS, which can occur at any stage of infection called neurosyphilis. The first line treatment of syphilis was benzathine penicillin G, and the number of doses are based on the state of infection. And for the treatment of the other state, I have summed up in this table. And for the syphilis infection in people living with HIV, the clinical manifestation and treatments are similar to persons without HIV, but however, they may also be more likely to develop neurologic complications. So the people living with HIV and syphilis should have a careful neurologic examination. Additionally, they may have a higher incidence of insufficient serologic response after treatment. And this is the summary of syphilis follow-up that's shown in this table. And if the patient has evidence of treatment failure, such as inadequate serologic response or sustained fourfold increasing or recurrent signs or symptoms, they should be re-evaluated for the neuro exam. And if there are some abnormal neurologic examination, this CSF examination is recommended. And if you see the table on the left-hand side, you will see the RPI titer of the people living with acute HIV infection in our cohort. And you will see that the RPR titer had good response after treatment in 2 years. But after that, the titer started rising. This is quite common in the person who had ongoing risk of reinfection. And this is the study of Dr. Kamon Ratana at Pathariya Clinic, Chulalongkorn University, to assess the sensitivity of syphilis rapid diagnostic test and the prevalence of syphilis in adolescents. The results show the prevalence 20% in adolescents with HIV, which was higher than healthy adolescents. So the regular screening should be implemented in this key population. And let's now turn to the second case. A 21-year-old man had dysuria and recurrent urethral discharge. He was MSM insertive anal intercourse with HIV infection, and he had a history of multiple STI. In September, he had dysuria and he visited the SKI clinic and was prescribed azithromycin with unknown antibiotic for 7 days. Then the clinical was improved but not resolved. He revisited the STI clinic again with dysuria and he had urethral discharge, and the medical management was the same as the previous visit. the clinical still not resolved, so he came to the body CU clinic with obviously seen the urethral discharge. At that visit, we prescribed the ceftriaxone 500 milligram single dose and follow up the clinical again, and he stated that the clinical did not resolve, and he still had pain with urination and still had urethral discharge, as you see in the picture. And from this patient, do you think what is the most likely diagnosis for this patient? Who think he may have reinfection or resistant organism in this patient? Or maybe other pathogens, we may misdiagnosis. Okay. In this patient who with the persistent or recurrent urethritis, so we differentiate diagnosis for maybe he may have reinfection because he is still ongoing risk again and again, or may have resistant organism, or maybe the other pathogens such as the Mycoplasma genitalium infection. So we perform the urine multiplex real-time PCR for bacterial STI to find out the other pathogens, and also urine gram stain and culture from the discharge. And we prescribe ceftriaxone and levofloxacin, the quinolone, in case of infect with other pathogens. For the patients with persistent and not resolved after treatment with common antibiotic for gonorrhea or CT infection, this is the indication for testing to find the causative organism for proper management. The molecular test for bacterial STI may play an important role for this patient. The tests that are available in our setting are multiplex PCR for bacterial STI and the other nucleic acid amplification or NAT test, and all tests have high sensitivity and specificity. But in this patient, we need to find the pathogen other than gonorrhea or chlamydia, so we perform the multiplex real-time PCR, which can detect 6 pathogens as you see in the slide. And the result was positive for Mycoplasma genitalium. And then we follow up the patient again by phone, and he reported that the clinical improved, but he still had dysuria some days. So we prescribed doxycycline for 7 days, followed by moxifloxacin for 7 days, as it is a regimen for macrolide resistance because of the resistant testing is not available in our setting. And after that, the clinical was resolved. Mycoplasma genitalium can cause symptomatic and asymptomatic urethritis, and it can be detected in around 40% of persistent or recurrent urethritis. It is an extremely slow-growing organism, so that the recommended diagnostic test is PCR testing. The clinical clues of suspected this organism are non-gonococcal urethritis with persistent or recurrent symptoms. And for the treatment, the 2-stage therapy are recommended for Mycoplasma genitalium treatment. Doxycycline is provided as initial therapy, which can reduce the organism load, and followed by the second drug using the resistant guide therapy. Azithromycin for macrolide sensitive, or moxifloxacin for macrolide resistant. And the resistance to azithromycin has been rapidly increasing. Therefore, if the resistant testing is not available, doxycycline followed by moxifloxacin is the recommended regimen. And let's now turn to the last case. A 23-year-old man had dysuria and urethral discharge again. He was MSM both insertive. Both insertive and receptive anal intercourse. He had history of multiple partners, so don't use a condom, and he is training prep. What is the most proper management for this patient who choose A, ceftriaxone 200 milligram plus azithromycin? Please raise your hand. Or B, ceftriaxone 500 milligram plus doxycycline for 7 days. Okay, most of you choose B. Okay, let's see the progressions of the case. In this patient, he is a participant in gonococcal vaccine study or bacterial study, so we perform the PCR testing for all possible routes of gonorrhea infection, and the result was urogenital, rectal, and pharyngeal gonorrhea infection, and urogenital and rectal CT infection. This is a good example to demonstrate that the infection may not associated with the symptoms, and we have to keep in mind with the other co-infection. And this is a cross-sectional study of MSM in China, enrolled around 400 participants at STI clinic and swab for PCR testing. Unlike urethral infection, most rectal and pharyngeal gonorrhea or CT in MSM are symptomatic, so we have to look up for the other bacterial STI. Gonorrhea and chlamydia are commonly identified in infectious urethritis, and clinical manifestations are vary in both organisms, and asymptomatic infection is also common, especially in the chlamydia infection. The gonorrhea can be diagnosed by the gram-stain basic test and the confirmation test, culture and PCR testing. But for the non-gonococcal diagnostic test, the recommendation to use the PCR testing due to it's difficult to be cultured. And there are some problems in the gonorrhea culture, especially for asymptomatic urethritis, because of it had low sensitivity, and this organism is fastidious and fragile, so careful consideration with proper method for specimen collection and transportation is required. For the sampling collection, suggest we should delay the specimens until 2 hours after last void. And for the swab, suggest not using the cotton tips due to it might inhibitory or toxic to the organism. Instead, we suggest using the drag cone or rayon swab and let it remain for 10 to 30 seconds to allow the absorption of the organism before inoculation. And this organism has demanding nutritional and environmental growth requirements, so it requires a special media called modified thiamartin agar, which contains antibiotics that will inhibit the growth of other bacteria or fungus, and we have to put it immediately into the carbon dioxide-enriched atmosphere before transportation. It's the important thing to improve view of culture positive. And the picture in the right-hand side show the commercial culture media that we used in the gonococcal vaccine study. It's called Intre-GC, and it's a modified thiamartin media which are ready to start carbon dioxide production at point of care by puncture the carbon dioxide seal after finished inoculation. So no need the carbon dioxide incubator during transportation, and it may improve the yield of culture positive gonorrhea. And for the surveillance of gonorrhea resistant project, on the left-hand side, you will it is the percentage of gonorrhea isolated with elevated MIC to ceftriaxone, cefixime, and azithromycin. And you will see that azithromycin resistance in gonorrhea is an increasing concern. And the systematic review and survey of gonorrhea susceptibility data show the increased MIC from 14 to around 30% in both ceftriaxone and azithromycin. This surveillance leading to the updated recommendation treatment for gonorrhea. The high-dose single-agent therapy with ceftriaxone is the preferred regimen. This is higher than the previous recommendation due to the concern of rising MSC worldwide, as you see in the last slide. And treatment for co-infection with chlamydia should be administered when the co-infection had not been excluded. And for the regimen treatment of non-gonococcal urethritis, the empiric treatment should be targeted against chlamydia infection, as this is the most likely pathogen. So doxycycline twice daily for 7 days is the first line treatment for chlamydia infection and non-gonococcal as well. These recommendations are based on the several studies suggesting microbiological rate of doxycycline is higher than azithromycin for chlamydia trachomatis infection, and they concern that the single-dose azithromycin could promote mycoplasma resistance, so the current guideline recommend to use doxycycline. And for the partner management, recent sex partner in the past 2 months should refer for evaluation and treatment. And in some situations that the partner are unavailable, expedite partner therapy may an alternative strategy. by deliver the drug to the partner by the patient. And I will have take a look at the prevention of the bacterial STI. For the data to support doxycycline as post-exposure prophylaxis or doxy-PEP comes from 2 clinical trials in France and in the US, and both trials study in MSM and transgender women. The participants were randomly assigned into 2 groups. One group was given doxycycline 200 mg after unprotected sex, while the control group didn't receive any drug. And in both trials, doxy-PEP was very effective in reducing bacterial STI, leading to stop trial early in the US, and the results are under review for publication. And in terms of the vaccine prevention, WHO prefer the vaccine efficacy for around 50 to 70% for gonococcal vaccine, which predict to prevent the gonococcal resistance and potentially eliminate gonorrhea. But at this time, the vaccine against gonorrhea is not yet available. But from the current study found that the Neisseria meningitis vaccine may produce cross protection against Neisseria gonorrhea, and the efficacy of this vaccine for gonorrhea prevention are under study. And this is the timeline findings of study associated with gonorrhea. The RCT of licensed meningococcal B vaccine to prevent gonorrhea have either started on or plan to start in the US, Australia, and also Thailand. And we are one of the sites of Bexero study, which is ongoing RCT that evaluate the efficacy of Bexero vaccine in adult risk group. And in conclusion, the adolescents are at a greater risk of STI. The proper screening and management are the key strategy. And in terms of bacterial STI prevention, they also have an antimicrobial PEP such as doxy-PEP and vaccine that may be of interest in the future. Finally, I'd like to thank everyone who was involved and support me for the presentation. Thank you.
Thank you, Dr. Pathariya, for excellent talk. Any suggestion, comments on STI? I think STI is it's day-to-day clinical practice that we see when we have provide service for HIV. Professor Garrett or Ajahn Kunkanya, any comments? Okay, yeah.
Thank you. My name is Dr. Khánh. I'm from Hanoi, Vietnam. And my question, I have 2 questions for you. The first question is, what is your opinion on the treatment for asymptomatic mycoplasma? Because when we tested clients for some STIs like gonorrhea, chlamydia, sometimes we accidentally found some asymptomatic Mycoplasma genitalium patients, and I wonder if we should treat or not those clients with doxycycline and moxifloxacin. Yeah, and my second question is, what is your opinion, or is there any kind of study on the problem of antibiotic resistance if we use STI prophylaxis like doxycycline? Thank you. Yeah.
Okay, for the first question of asymptomatic Mycoplasma genitalium, there are many studies that show that they can resolve by themselves without treatment. So I think if there are no or asymptomatic infection, then the host is healthy adult or healthy adolescent and had no underlying disease, maybe wait and see. But if they have symptoms, I think it's definitely treat. And for the second question about the resistance after use the doxy as post-exposure prophylaxis, right? I think we no data from now because of the doxy-PEP didn't implement. It's just only in the research project. Thank you.
Okay, so I think on behalf of the organizing committee, we are very. Oh, any questions? Oh, one last question, please.
are the evidence? Can you share with us? Thank you very much.
For the antibiotic resistance in Thailand, I think we have no data now, but we use the data that have surveillance in systematic review that will survey in the Southeast Asia and found that we have increased elevated MIC especially in azithromycin. So we follow the guideline of CDC to use the first line drug to be doxycycline. Thank you.
I think the trend is trying to prevent drug resistance, and therefore people try to use ceftriaxone in a higher dose because of the trend. Actually, right now we don't have the problem of increasing ceftriaxone resistance at all in the country. But the trend of MIC seems to be increasing a little bit. So people have the feeling that we better treat with the optimal dosing, which is double dosing. And for azithromycin, there is some data that there is some resistance developing, and that's why the double treatment may not be the case in this anymore, because doxycycline seems to be better than azithromycin. So we used to have the guideline just like Malaysia. We just only recently just changed, I think in less than a year. And perhaps Malaysia would have to change accordingly as well, because STI cross the border.
Yes,
And that.
Because we are neighbors, and it's good to know exactly what's happening in Thailand.
Right.
Our guidelines basically, we usually use the resistance pattern to decide on the antibiotics, so that's the reason.
Right.
Thank you.
Thank you.
So I think this afternoon we have a chance to share and learn from the speakers and also from the audience to focus on many topics on pediatric and adolescent, starting from pediatric DTG access, which is the important antiretroviral drugs. We talk about prevention in adolescent and also other co-infection, and also learn that many settings, especially in Philippines, also have encounter with limited access and also many advanced HIV disease. So I would like to thank you for all your participation and hope you enjoyed this evening, and we meet again tomorrow morning in the plenary session. Thank you very much.